Hello, everyone, and welcome to today's SOC-ADM webinar presented by the Simons Foundation and the Interactive Autism Network. My name is Casey White, and I'm the project manager for the Simons Simplex collection at the Simons Foundation. We're so glad that you could join us today, and we thank you so much for taking the time to participate in the EN community. Before we begin, I'd like to say just a couple of words about how today's webinar will work, just in case you've never attended an online meeting before. Today's presentation will be shown in a window on your computer, and the sound will come through your computer speakers. We are recording this webinar, and we will post it on the EN website so that it can be viewed at a later date or sent to others who may be interested. Please be aware that in order to minimize disruptions, all audio except the presenters will be muted for the duration of the webinar. So if you speak, we will not be able to hear you. However, you can use the chat box at the left of your screen to ask questions. These can be either technical in nature or for the presenter, and only the leaders of the webinar will be able to read them. At the end of the webinar, we will have a few minutes for a question and answer session, and we'll take these questions directly from the chat, or you can send them to via email on the email address you see on your screen right now. Please note that the speaker is not able to provide advice regarding your child specifically, but she's happy to answer other topical questions. I think that's all the webinar information I have for you, so let me just take a moment to introduce today's speaker. I'm pleased today to welcome Dr. Katherine Gotham to the SOC-ADM webinar. Dr. Gotham is a clinical psychologist and assistant professor of psychiatry and behavioral sciences at Vanderbilt University School of Medicine. At Vanderbilt, the focus of her research is on emotional health in adolescents and adults with ASD. Dr. Gotham has also been instrumental in the development and validation of several gold standard clinical diagnostic tools, such as the Autism Diagnostic Observation Schedule, or the ADOS, in collaboration with Kathy Lord. Additionally, Dr. Gotham was a clinical consultant to several of our SSC sites while they were evaluating participants for the SSC study. As part of our SOC-ADM webinar series, we try to highlight topics that the community of families has told us are important to them, and this is one of them. Our success with this goal depends on scientists like Dr. Gotham giving their time to talk about families, about their research, and we truly appreciate her joining us today. So today, Dr. Gotham will speak to us about the current state of research and clinical understanding of causes, symptoms, and treatments for mood problems in autism, with a focus on adolescents and adults. So at this time, I'd like to turn the webinar over to Dr. Gotham, and to thank you so much again for joining us today.
Oh, thank you so much, Casey. That was a lovely introduction, and thank you all for being here and for inviting me to do this. This is a topic that really means a lot to me, is near and dear to my heart. I just want to make a brief disclosure of conflict of interest first. I receive royalties and or honoraria for training others onto standardized autism diagnostic instruments, but we are not going to be discussing either of those instruments today, so this is just a formality. But again, it's really an honor to be asked to speak about this really important topic. So one of my primary research interests is understanding the mechanisms or pathways by which people with ASD become depressed, in the hope that that can shape how we go about treating depression in this population. So I wanted to take just a moment up front to thank the people that shaped this aspect of my career. I had the privilege of training under Dr. Kathy Lord, and which was an amazing experience. I participated in one of her adult ASD social groups for many years, and it was really noteworthy that in this wonderful group of people, here you can see some of their feet, our feet, depressed moods seemed to come and go quite frequently, or in some members just remained at a consistent mild level throughout the decade or so that we knew them. And I always assumed at that time, for a long time, I assumed that this was an issue of fulfillment, and that many group members didn't have the things that they really wanted, sometimes jobs, often romantic partners. But then my colleagues at one point worked really hard to set up a particularly bright and socially motivated member of the group with a job that he really liked. And he was proud of the work he did, had a lot of positive social contact through this job. But then within a few months, he went into another depressive episode, and had to quit the job. And that always stuck with me, that there may be more to depression and ASD than just whether or not someone is meeting their life goals, although that is incredibly important. I don't mean to minimize that. But there's a lot, and this is a weighty topic. And finally, I wanted to thank Dr. Summer Bishop, a friend and a colleague of mine who around that same time said, we need more answers about depression and ASD. And that was at a time when I was so interested in this, but had sort of dismissed this as being too small a proportion of the population to be a practical focus of my career. But Summer's a big picture thinker, and she was so right about this. So I owe her the very direction of my research career in this way. This is what I hope that we cover today. I already talked about speaker background, but we'll also talk briefly about the title, and then why should we care about depression and ASD, meaning why should we devote time and resources to this topic. We'll discuss how depression presents in ASD as far as we understand it, and some issues with screening and assessment of this comorbidity. By comorbidity, I mean when two diagnosable disorders like ASD and depression are both present in the same person. And then we'll move on to potential causes for why we see such high rates of depression in ASD, and there I'll focus on a couple of potential pathways over many others possible. We'll briefly talk about treatment and prevention, which unfortunately is understudied to this point. And we'll end with some special considerations such as depressed mood in minimally verbal individuals and the issue of suicidality in ASD. And then, as Casey said, when we wrap up, we'll be open to questions. So there are very high levels of mood problems in people with ASD when we based on standardized self and parent report questionnaires about depressive symptoms. Lots of those people with high symptoms might not meet strict criteria for major depressive disorder based on the DSM-5, which is the American Psychiatric Association's manual for the diagnosis of mental and behavioral disorders. For a formal diagnosis, you need to have at least 5 symptoms experienced to a significant degree. So for example, nearly every day for most of the day, these symptoms would be present over a 2-week period, or significant weight loss, not just lower appetite than usual. So the bar is set relatively high. Excuse me. So is mood still a problem in those who don't qualify for a depression diagnosis? For many people with ASD, yes, it is. In the general population, research indicates that sub-threshold mood problems are not significantly different in causing impairment in functioning compared to those mood disorders that fall just over the threshold and do meet criteria. So in that case, we want to take seriously those mood problems that cause clinical impairment beyond that which is caused by autism itself in people with ASD. So throughout this talk, I might use depression and depressed mood interchangeably, but the focus really is symptoms of depression that cause clinical levels of distress or impairment in functioning, regardless of whether or not they meet diagnostic criteria for depression. And then the next part of the title refers to what we think we know and what we don't. And that's just to underscore the fact that despite early efforts from clinicians and researchers such as Drs. Mohammed Ghazadeen, Janet Lanehart, Pat Howland, and several others, this is still a young and emerging area of study, and there are a lot of gaps in this literature. So we think the presentation of depression depends on age, on level of measured intelligence, and level of verbal skills. And I tried to convey with this table, this leaves us a huge area to cover given these developmental effects. And so let me see here, these developmental effects of, as you age and these participant characteristics, this really affects the presentation and treatment implications for depression. So any one of these cells in this table defined by developmental or functioning level could be, even should be, its own topic of discussion, but we just don't have the data to address them all yet. So in this presentation, I'll try to highlight broad topics that may apply to several age or ability levels at once, and I apologize ahead of time if some or most of this doesn't end up applying to you. In terms of the whole talk, I invite everyone to please just take anything that might work for you and leave the rest behind. So depressed mood in ASD, why should we care? First, I argue that we should spend more time talking about depression in ASD and more resources studying this because it applies to a significant minority of people with ASD. And within some age and functioning groups, it in fact appears to affect a majority of people with ASD at some point in their lives. So based on research sample characteristics and study design, there are widely varying estimates of prevalence of depression in ASD, ranging from 1.4 to 70%. Again, this variability is due in large part to whether studies focused on one point in time versus at any point in that person's life, whether they focused on children versus adults, and importantly, how they assess depression. So for example, all the way from parents checking a box to indicate their child has ever received a diagnosis of depression, all the way to studies that conduct a full structured interview and clinical assessment for depression as part of the study protocol. So just know at the low end of this range, that number is from a study of children and young teens who are less likely to have depression in general by that point, pre-puberty. And even though less than 2% met criteria for depression, an additional 11% of that sample had significantly elevated depressive symptoms. And then at the high end of that range, that's based on a gold standard structured interview in which 70% of adolescents and adults with ASD were found to have lifetime histories of depression that met full diagnostic criteria, which is an enormous, that's a huge percentage of the population. Many families, clinicians, and researchers alike believe that depression rates are on that higher end are more representative. And several studies have reported depression to be the most common comorbidity in adults with ASD and a leading form of clinical impairment in adults with ASD. And another reason that we should care is that depression matters. It affects functioning and quality of life for the individual, and it affects the family and support network. First, when ASD co-occurs with depression, some of the existing difficulties noted in ASD may be exacerbated. So lack of motivation to take part in social situations and develop these skills can contribute to further withdrawal and spark a cycle of worsening social difficulties and social withdrawal. We see even greater impairments in adaptive behavior skills in individuals who have both ASD and depression as compared to ASD without depression and depressed individuals who don't have ASD. And then people with co-occurring ASD and depression tend to report decreased quality of life. And we also know increases in some of the most challenging behaviors seen within ASD, such as increased aggression and self-injury, as well as highly elevated rates of suicidal ideation or thinking about hurting oneself or ending one's own life, which I will talk about further near the end of this presentation. Depression is associated with increased service use in people with ASD, and that's in the context of already scarce resources, especially for teens and adults with ASD, and also with increased burden on families and caregivers. So depressed mood within the autism spectrum is common and impactful, and it is an important public health issue in the ASD community and should be taken seriously by supporters of this community. What does depressed mood in ASD look like, and would we know it if we saw it? First of all, the diagnostic, just generally, what is depression? Diagnostic criteria for a major depressive episode includes 5 or more symptoms present during the same 2-week period and which represent a change from previous functioning. At least one of the symptoms has to be either depressed mood, so feelings of sadness or emptiness, or loss of interest or loss of interest or pleasure in things that the person usually enjoys. And I really like this figure taken from Mental Health First Aid's website, which shows how common symptoms of depression can be grouped by, let me get the little pointer out, starting from this, going clockwise from this upper left quadrant. Feelings like sadness, emptiness, or irritability, thoughts like self-criticism, indecisiveness, suicidal ideation, physical symptoms like exhaustion, unexplained pains, sleeping or eating either too much or too little, and then other behaviors such as social withdrawal or neglecting self-care. So people with ASD can experience some or all of these same traditional features of depression. This again includes increased sadness or crying, changes in appetite and sleeping patterns, increased social withdrawal and lack of motivation, in general, not just about social things potentially, as well as other cognitive symptoms such as negative thoughts about oneself, feelings of guilt, failure, worthlessness, hopelessness. And these cognitive symptoms previously were thought not to characterize depression on the autism spectrum, but recently we have some evidence to suggest they might be even more common in ASD than they are in the general population. Other symptoms or manifestations of depression in ASD may be different than those seen in the general population, and these symptoms often are better explained as changes in already existing behaviors, such as changes in intensity of a restricted interest, increased frequency or intensity of repetitive behaviors, or greater irritability, aggression, self-injury, etc. However, while it's important to be aware of these sorts of changes, and that's what I'm advocating for in this talk, it's also important to note that behavior changes such as these don't exclusively signal the presence of depression. It's important to consider other causes, including something stressful going on, like bullying, an undiagnosed medical issue perhaps, or just general developmental or pubertal changes. To further complicate the picture, many of the common symptoms of depression that we just touched on, such as sleep problems, poor concentration, social withdrawal, they can also be considered behavioral correlates of ASD itself. It also may be easy to overlook depression in ASD if awareness of depression within that individual's support network relies on the individual's own recognition of their feelings and their ability to verbally express this recognition or those feelings. And these are two commonly difficult areas for people with ASD. So autism-related impairments in emotional insight can sometimes complicate, complicate a person's own experience of depressive symptoms, how or whether they notice them, understand them, or tell others about them. And then observation of depressive symptoms within that network, that support network, might be confounded by ASD impairments, ASD-related impairments in communicating affect through facial expression or intonation. So for example, in a typically developing person, flat affect and flat tone of voice might indicate depressed mood, and in a person with ASD, those same features might not indicate anything about their emotional state one way or the other. For another person with ASD, they might indicate depressed mood. And finally, we're not sure whether people who have greater verbal skills are particularly affected by depression or just more easily identified. And so there may be additional currently unrecognized ways in which depression manifests in people with ASD who are minimally verbal or less cognitively able to express or identify those concerns. So even when we do recognize that we need to assess for depression in a person with ASD, the screening or assessment process can be difficult for a number of reasons. First, it may be hard to get a person with depression motivated to seek help whether or not they have ASD. But then, for people with an autism spectrum condition, we have the added difficulty of not knowing how well our standardized instruments for depression assessment work in this special population. As we just discussed, depression measurement relies almost exclusively on emotional insight and verbal or written self-report, and both of these can be common difficulties for individuals with ASD. Parent report might be a better alternative in some cases, but many studies report large discrepancies between self and parent-reported scores in the ASD population, not just on depression, but certainly also on emotional health concerns. And when you have big discrepancies between what a parent reports and what a child, adolescent, or adult reports, it's hard to know where to put more weight or how to sort of combine those into a most accurate picture. And finally, depression assessment in the context of ASD can be difficult because some of the symptoms of depression and ASD can appear to overlap, as we already noted. And that also seems to work in the other direction. The presence of psychiatric disorders, including depression, has been shown to reduce the accuracy of common autism diagnostic instruments in picking up ASD. Okay, so here we're going to move to turn toward mechanisms underlying depression and ASD. There are many neurobiological and psychological phenomena common to both populations, meaning people with ASD and typically developing people with depression. And we hope that identifying specific mechanisms will allow us to better understand this comorbidity and provide an entry point for tailoring interventions. The risk for mood-specific problems in ASD, again, is largely unstudied to this point, but appears to have genetic and neurobiological factors, psychological factors, and finally factors associated with the social context. And very few of these possible indicators of mechanism in autism and depression have been explored by directly comparing people with ASD and typically developing people with depression. And then even fewer have been explored for the explicit purpose of understanding the development of depression within ASD. So next we're going to consider these domains one at a time over the next couple of slides, but almost surely there is an interplay of risk among or across these various domains. Many studies have replicated the existence of a large subgroup within the autism spectrum that has an elevated rate of familial mood disorders documented prior to the birth of a child with ASD. And this suggests that the two types of disorders may be related clinically and genetically. Just to clarify, this does not mean that a family member who had depression in any way caused their child's autism or caused their child's depression, but rather it suggests that similar genetic markers or resulting mechanisms might contribute to both depression in a parent or other family member and to ASD and or depression in the child of focus. So how are those genes conveying risk? This is not my area of expertise. In general, I would say as a field, we don't know. But there are several atypical biological and specifically neural processes that have signal in both a general depressed and general ASD population. So those seem like a logical place to start looking. And here I've listed just a few examples that stood out to me, but certainly there are others. The high co-occurrence of depression and ASD also seems reasonable from a psychosocial perspective. So there are many constructs that have been linked to depression in the general population that are exacerbated or heightened in general ASD, such as loneliness, lack of social connectedness, perception of low peer approval, and high social incompetence. Which might lead to those negative cognitive attributions that we discussed previously. Coping skills is an interesting area for further study in ASD. In a 2016 article that I failed to cite here, we noticed a significant relation between stressful life events and mood symptoms in a small sample of, I guess, slightly less than 40 youth with ASD who were interviewed in their last year of high school. And nearly 90% of those with clinical level mood symptoms had at least one life event that they experienced as traumatic, compared to 40% of those with minimal mood symptoms. And so the association between trauma and depression is well known in general psychology, but this might be a particularly relevant pathway in ASD. We don't know yet if traumatic events are more likely to happen to people with ASD, or if people on the spectrum are more likely to experience stressful events as traumatic. And we also don't know how the strength of that association between trauma and developing depression compares between ASD and the general population. We do know that people with ASD tend to have higher rates of several stressors, including bullying, unemployment, lack of independence in daily life, romantic unfulfillment, stressors that predict depression in the general population. So in short, they have a lot that they could potentially feel depressed about. And that brings us to the social or societal context in which we locate ASD at this point in history. And as a quick example, I want to tell you about one specific finding. In a sample of 50 adolescents and adults with ASD, we found that participants' perception of their own impairment was strongly associated with their depressive symptoms, regardless of their degree of impairment as rated by a clinician. So as you see from the red triangles and this solid red slope line, individuals who endorse greater ASD impairments in themselves tended to have higher depression scores as well, with a moderate effect size. But what was particularly interesting is that participants with these higher depression scores didn't see themselves as having just globally higher ASD symptoms. Instead, the findings seem to be driven particularly by their responses that indicate a lack of independence or goal achievement in particular. So back to the social context, a separate research finding I want to tell you about came from a large EAN sample, so elective survey respondents from the Interactive Autism Network, some of whom may be in the audience today. And if so, many thanks to you for your participation in that adult study. In that study, we were surprised to find that more able adults with ASD endorsed societal understanding and acceptance of ASD as their number one most important priority for future research. And this was also rated as the top research priority by family caregivers of adults who were not able to report on themselves. Clearly, there is a stigma that remains for adults with ASD, despite widespread public health campaigns about recognizing autism in children. And it's possible that that stigma influences depression and ASD if, for example, it negatively affects the way some people with ASD view themselves, or if it's associated with limitations on resources like jobs or housing that would support better outcomes and quality of life in adults with ASD. So we've already kind of discussed the fact that although research on depression within ASD is limited, we can use what we know about the development of depression in the general population and try to apply that to how we think about depression and ASD. And just to clarify, we're not searching for one or two, quote-unquote, right answers. No doubt there are lots of pathways to depression in both the general population and in ASD. But these two I want to single out right now are two pathways from typically developing research that seem particularly applicable to ASD. We've already touched on the social connectedness pathway. The simplified pathway suggests that individuals who experience a lack of social connection or support in their lives tend to have greater feelings of loneliness. Sorry, these slides didn't necessarily translate to the system very well. This is loneliness, which can in turn contribute to the development of depression. And though this model is developed based on research in typically developing people, we observe both a lack of social connection and loneliness occurring at greater rates usually occurring at greater rates within people with ASD. And this might also explain why depression seems to increase with age, at least through young adulthood in this population, as that tends to coincide with increased social motivation in many people with ASD. So I like this hypothesis because if we find evidence to suggest this pathway, it has really clear treatment implications. If people with ASD desire social contact, then let's support them in achieving that. And I'll talk a little bit more about that soon. Okay, this one also didn't translate perfectly, but you can get the picture. The rumination pathway stems from the tendency of depressed individuals to ruminate or to think sometimes continuously or repetitively, often about something related to negative events. And this pattern of thinking is well documented in the general population as being higher in people who go on to have depressive episodes. So it's thought to contribute actually to the development of depression. And again, this pathway makes a lot of sense in the ASD population, given that many people with ASD are already predisposed to inflexible or repetitive styles of thinking. So they may become focused on negative events, causes, or outcomes the same way they become focused on a specific interest, and that might put them at higher risk for depression. So to look at this another way, people with ASD are more likely to engage in repetitive behaviors, including manifestations of cognitive rigidity, and it's possible that when that cognitive perseveration is focused on positive or neutral topics, we observe this as strong fixed interests. But that same predisposition to repetitive thinking when focused on negative events or thoughts might represent a pathway to negative affect or depressed mood. And as I mentioned earlier, we have some data to indicate that adults with ASD have elevated levels of negative self-attributions, such as sense of failure, guilt, and shame, compared to similarly aged, typically developing peers. And we don't yet know how important that self-referential component is in this process. But certainly it makes sense that dwelling on negative aspects of oneself might be particularly strongly associated with becoming depressed or maintaining depression. in a small subsample from the study that I described previously, rumination also tended to influence that association I told you about between perceived autism impairment and depression scores. Let me find my little pointer here. We observed that depression scores tended to be highest in the group with both higher perceived ASD impairment and higher levels of rumination, whereas merely perceiving one's own impairment without ruminating on it was not necessarily associated with elevated depressive symptoms. So from this, we might hypothesize that the development or maintenance of depression in ASD could be related to the extent to which individuals see themselves as impaired or see limitations on their lives and then get stuck on those thoughts. Okay, so moving on to treatment. Very little is known about treating depression in ASD, unfortunately, but some existing treatments are promising, maybe promising anyway, for adaptation to the ASD community. I think I might have skipped. There we go. So this slide outlines some common approaches to depression treatment, and we'll talk a little bit more about the first two bullets in the next couple of slides. In terms of the last bullet about medication, this is probably the most common treatment approach at this time. It's important to note that antidepressant medications are commonly prescribed to individuals with ASD for reasons other than depression, and it's also important to be aware that in some cases, especially children, teenagers, and young adults may experience an increase in suicidal thoughts or behavior when taking antidepressants. You probably heard that before, especially in the first few weeks after starting or when the dose is changed. So this is not a reason not to try these medications if they're needed, but people of all ages starting antidepressants should be watched closely, especially in those beginning stages of treatment. Okay, so I want to focus for a moment on cognitive behavioral therapy. CBT is a form of psychotherapy that's based on the idea that how we feel is directly related to our thoughts and interpretations of things. So examining our thoughts by making them more explicit and examining how accurate they are, this can be a very successful method of changing our feelings and behaviors that maintain depression. And we are moving toward adapting and testing CBT for depression in people with ASD. It has been shown to successfully treat anxiety within ASD, and definitely also to successfully treat depression in the general population. I've included this website at the bottom for the Academy of Cognitive Therapy as a means to identify CBT therapists in your area if you're interested. There are a lot of great CBT therapists who are not on that in that academy or in that sort of association, but this is a good resource for finding one CBT therapists. And then next I wanted to touch on the idea of behavioral activation. Behavioral activation branched off from CBT, and the primary difference is that where CBT strives to change thinking patterns in order to change feelings and behaviors, BA strives to change behavior first to improve those feelings. And it's important to focus on activating behavior toward both some things that are easy and fun and easy to have success in, but also some things that are challenging but meaningful. So for people with ASD, a great example of that latter category might be activities intended to increase self-help and adaptive behavior skills. And to my knowledge, behavioral activation has been largely overlooked and understudied in the ASD population. But I think it's a really promising lead for us because first, it can be applied to less verbal populations within ASD, and second, because we have data from Julie Lowndes-Taylor and others' work to indicate that minimally structured lifestyles, for example, your days and weeks have few set obligations or activities, that can be associated with poor emotional health outcomes in people with ASD. So again, behavioral activation equals increasing engagement in both easy and pleasurable activities, but also harder or meaningful activities, and that can be helpful in combating depression. So I want to say a few words on focusing on prevention. First, along the idea of having an emotion regulation toolbox. This idea is to Prepare personalized strategies ahead of time when you're feeling relatively well, or when your child is well, if you're a parent in the audience today. List out what helps you to relax, to feel less anxious, feel more invigorated, what generally helps to calm your negative thoughts, etc. And then when you feel yourself slipping down into a sad, empty, anxious, or otherwise negative mood state, or if you notice that in your child, try to choose off this menu of tools that you created for yourself. So this is a child-based example and also a very generic example on the slide, but be specific in your own toolbox/menu. Write down phone numbers of people you can call, places that are easy to get to that have beautiful views or happy memories for you, specific episodes of shows, TV shows that would make you laugh, specific songs that help change your mood. Maybe gather together pictures of interesting things or special people, so it's like a tangible toolbox, and so on. And then, if at all possible, try to pick out a pattern of what kinds of thoughts or situations most commonly lead to your own negative mood states. And you can get help from trusted family members, educators, therapists, others in your support network for creating a plan of how to deal with those thoughts or how to prepare for those situations. Different responses might be more or less effective for different situations. Okay, so circling back to prevention, remember that we discussed the research finding that adults with ASD and caregivers of adults with ASD both ranked the need for social acceptance of people with ASD as their #1 autism research priority out of many options. Well, this part of the talk is not at all backed by data that we have at this point. We don't have data on this at this point. But I think that that finding points to the idea that being someone with ASD in a world that does not accept differences in social abilities equals very hard work. And sometimes when you work very, very hard every day with fewer infrequent rewards, you just get tired out. So first, this is just a call for all of us to continue a special crusade in that we need to contribute in small and big ways to improving the social acceptance of people with ASD. We've made such huge strides in awareness and actually also in acceptance, but there's so much farther to go. In the meantime, before we change the world, we can try to build that acceptance into specific individuals' daily lives through kind of micro worlds to combat social isolation. So clubs, theater groups, jobs, online communities, etc. And as parents, you might have to build your own depending on your area or what's available. See if you can enlist friends on the spectrum, maybe some nice, upstanding high school or college students to participate in book clubs or coffee hangouts at set times. And as carefully but directly as possible, set boundaries up front so that people's feelings don't get hurt. For example, I want to be friends through book club but not date each other. In the same vein, try to identify one ally at school or in structured activities so that you or your child with ASD has a bright spot in a situation that might otherwise be difficult to navigate. Try to enlist educators to help with peer matching type programs and with the purpose of getting systems that really work in practice, not just on paper. Incorporate special interests, which often provide people with ASD with a sense of success or mastery. Try to connect with other people with similar interests. Try to eat healthy and sleep well. Seek out therapists that deal with those specific issues if you can find them and if you need them. Get exercise. Importantly, as we already touched on, structure your time. So seek available community resources to do this in creative ways by getting a job if possible, but joining a job club or social group if not, or in addition to. If there really aren't resources in your area, try homegrown strategies for this too. So for example, maybe a teen or young adult can be helped to set and reach the goal of cooking for the family once per month. And they would need help in planning the meal, shopping for it, preparing it, setting the table, etc. Routine exercise can be part of your structured week, and this is all in line with that behavioral activation principle. And finally, be aware of your own mood or your child's mood, and especially consistent, persistent changes in mood or behavior. And I say on the slide to have tempered vigilance, again, because these changes could be due to reasons other than depression. However, after all of that, know that prevention doesn't always work. So back to that personal example I gave in our first slide, even for an individual who had a structured social group, a supportive family, and a new job he liked, it didn't prevent a recurrence of depression. So temper my advice with the realization that as parents, friends, or other supporters of people on the spectrum, we can't always fix or prevent problems regardless of our best intentions and our hardest work. And in that case, get professional help. That might be the person's pediatrician or general practitioner to start with. Explicitly request a depression screening to the degree that you still have influence over that person's medical care. I greatly encourage psychotherapy in addition to, or in some cases instead of medication. If you're in a geographical area or a financial position which allows you to access psychotherapy, be prepared to shop around until you get a good fit between yourself or your child and the therapist. Ask other people for recommendations of good therapists, and ask potential therapists directly if you're interested in a particular treatment modality. So do you have training and experience in CBT or behavioral activation? Or can you refer me to someone who does? And if you don't have these resources in your area, just supportive talking therapy can help some people. And sometimes educators are a great resource for helping identify emotion regulation strategies as well. Okay, so I want to get to your questions. We'll try to go fast, but I want to touch on these special considerations. I apologize up front because the minimally verbal population is a large proportion of those with ASD and don't deserve to be overlooked. Should be a primary rather than a special consideration. But in general, I want to touch on the fact that to assess for depression, you might want to rely more so on behavioral changes in this subgroup. In terms of professional treatment, behaviorally based strategies probably are sort of the best or the first course in addition to medication. And focus on increasing self-help skills, increasing social exposures. You might want to get creative here about trying alternative therapies like art, music, exercise, I'm not thinking of the right word, but horseback riding, and then things you can do like volunteering, incorporation of therapy animals, and things like that. Another special consideration, the role of identity on the spectrum. We noticed that for some older adolescents and adults with suspected ASD, that sometimes receiving a formal diagnosis it seems to be accompanied by great psychological relief and a sense of identity. And sometimes that actually helps depressed or other sort of co-occurring mental health issues. So if you suspect that you have an ASD, you might think about seeking out a formal ASD diagnosis from a reputable source or becoming involved in ASD support or advocacy communities. And then finally, suicidality. Research is beginning to focus on the increased risk for suicidality within ASD, and preliminary findings have reported really high levels, between 3 and 9 times more suicidal ideation in people with ASD than typically developing age peers. And some of the risk factors are thought to be similar to several things that we've already discussed, like perseverative thinking patterns and social isolation. One of the most important things you can do to get on the road to addressing suicidality is to talk about it. And this is true of non-suicidal self-injury as well. As clinicians, we're trained to just calmly ask outright about whether an individual is having these types of thoughts or behaviors, and then to respond with respect, a calm optimism, and the willingness to get involved and not just turn a blind eye. Well, parents can do all these things too. General research has shown that, with reason, individuals with suicidal thoughts are more likely to make a suicidal attempt. Not all of them, but it's more likely to be associated. So we want to act quickly here and take these thoughts seriously. And here I'm just going to direct you to Sally Bernard's excellent tips. I have this website here. She talks about, and there's a link to a longer article that she wrote in that link that I've written here. she talks about the tips of combating suicidality by paying attention, talking about it, preventing bullying, reducing social isolation, promoting healthy lifestyles, monitoring medication side effects, placing barriers on lethal means, and acting quickly. And so I think that was a really excellent blog, and I direct you to that for more information. And finally, if you're a parent or caregiver in the audience and you recognize depressive symptoms in yourself, one of the best ways you can help the person you love with ASD is to get help for yourself first. So to summarize, significantly depressed mood seems to be common and have great negative impact within ASD. It can be hard to recognize or assess for reasons that are related to ASD itself. Suicidality appears to be significantly elevated in this population. We do have some traditional or novel psychotherapy approaches that probably can be successfully adapted for this community, and behaviorally based treatments are preferable in less able groups. And finally, we just need to be better as a community about noticing it and being aware of it so we can act on what we see. And as researchers, we need to better understand what depression looks like in people with limited language and intellectual disabilities, and we need to be better at testing or adapting treatments and making effective treatments available. So I just want to end on this one positive note that some people struggle throughout their lives with recurrent depression. That is true. But for the majority of people, per research in the general population, but anecdotally also for those with ASD, even recurrent depression seems to get better or often go away entirely when you move past the young adult years. And I've heard really good things about movements like Project Semicolon, whose motto is "Your story is not over." Sometimes just providing that perspective that there's light at the end of the tunnel can be really helpful. So while we turn to questions, I'm going to leave, actually, first of all, I'll go just briefly touch on this. Thank you for your attention, and special thanks to these people and funding sources I have listed. And then while we turn to Casey to moderate questions, I will click back here and leave this resources for co-occurring mental health concerns up that was compiled by Dr. Neill Broderick. And thank you again for listening.
Thanks so much, Dr. Gotham. That was a really informative presentation, covered a really wide range of topics, which I really appreciate as well. I just want to remind our audience, too, that we are recording this webinar, and we will post it on the SOCADM website, which our chairperson has linked for you in the chat at the bottom left of your screen. And we're getting a lot of questions about that, Kate, so I just wanted to add that before I started. So we do have a lot of questions, and I'm my best to get to as many as I possibly can. So starting off with sort of diagnosis and symptoms of depression, we have several people who are wondering if symptoms of depression vary between adults and children, or between males and females, or different considerations there, or different races. Anything you might be able to say about that topic?
Yeah, that is a very interesting question. First, between adults and children, well, first I should back up and just say there really is, just like there's a various presentation of ASD itself, there are varying presentations of depression across age ranges, both in the general population and in ASD. So there's not just one thing that we can kind of isolate as this is depression. One common difference in terms of lifespan is that often you will tend to see a presentation of increased irritability and withdrawal in children versus the more depressed or empty mood, sadness or tearfulness that you might see in adults. But again, it's not one size fits all. So you definitely could see sadness and depressed mood in children as well. Between men and women, that is another very interesting topic. And in part, I sort of purposely left it out of my talk because it was such a big packed talk to begin with, and this is such a big packed issue that it was hard to even fit it in. What I have noticed in my own research is that we do seem to see, again, this is anecdotal because this is based on very small samples at this point, but higher rates of depression in females with ASD, which does seem to correspond to what is seen with the general population. By adulthood, in the typically developing population, you see approximately 2 women with depression to every 1 man with depression. And again, that might be an issue of men with depression sort of under-report or don't present as frequently for diagnosis and treatment, but it also seems to be something a bit more organic, whether it's biological or psychological in nature, that does seem to link women and depression more strongly than men. And finally, the idea of different races. To my understanding, and I'm sorry, I don't have the best sort of empirically or literature-based answer to this right off the top of my head, but my impression is that culture really does have an impact on how depression is conceived of, noticed, and referred for treatment. But within that, there are varying rates by different cultural or racial groups, but we do see depression in general across groups of people, and so it's something that does. I'll just stop there so we have time for more questions, but it doesn't, can impact everyone.
Sure, thanks. Yeah, that was like 3 questions in one, so I appreciate it. We have several folks who are asking about sort of generally supporting independent adult children with ASD and suspected depression, sort of encouraging them to seek treatment, or if you have any recommendations for how really a parent can just best support their adult child.
Yeah, I think it goes back to some of those ideas, which I had listed under prevention, but could also be seen as just, support in general, which is, following up on some of those ideas, but also other ones that you have about how to reduce social isolation. I think that's important. Opening lines of communication, so you're really asking people, that might not seem to lead anywhere, but you might have to just gently check in repeatedly about how people are feeling and how your adult child is feeling, and especially, asking directly about thoughts of hurting themselves or harming themselves. If it's difficult to increase social isolation along the lines of behavioral activation like we talked about, sometimes it's enough, or at least it's a huge step in the right direction, just to increase activity and structured time in general. So the idea of, just working together with that adult, him or herself, to come up with things that he or she want to do and or need to do, and will feel a sense of pride and accomplishment or mastery over if they can kind of structure their day. So I won't sort of reiterate a lot of that, but that was the intention I was trying to get at with those homegrown strategies, that by helping your adult, and again, you might, as a supporter of someone with ASD, really have to take extra measures to be involved and help organize some of these things if that person does have depression, because depression sort of tends to further decrease motivation and your ability to kind of organize and get yourself involved in these things. So by kind of helping to support getting out in the community, having structured time and things that improve your own mastery of your own self-care and your involvement in social things, I think is probably the best first start. And I'm sorry, I don't mean to minimize the importance of professional therapy. Also, again, help them to seek professional help in the ways we talked about.
Great, thanks. And sort of related, I guess, to seeking professional help, we have had some questions about whether or not there are individuals who specialize in the treatment of people with autism who also may have other disorders such as depression, and if that people should seek out someone who specifically understands ASD, or if any therapists, with the appropriate training could provide support.
Yes, I really appreciate this question, and I'm kind of like, I'm just sort of I'm sympathetic, because this is a really hard thing, I think, for a lot of families and individuals with ASD, that we as professionals kind of get siloed in the sense that, people who see themselves as autism experts say, well, I don't really do autism and emotional health issues. I don't know about treating emotional health issues within ASD. And then people who are professionals in emotional health treatments then say, ooh, well, I don't know about autism. I don't know how I'm not sure that I can do that. And then people who have dual diagnoses kind of fall down the middle of those two, and sometimes it can be really hard to get appropriate help. So I really sympathize with that. In terms of types of professionals, it depends on the area, but in general, psychologists and psychiatrists who, I think it probably makes sense to kind of start with people in your area who specialize in autism spectrum disorders and see if they have recommendations for who might be able to treat someone with emotional health difficulties within that. But if you don't have those resources, then I would, simply go to someone who is a specialist, who is a psychotherapist, for example, a clinical psychologist who does, or social worker or other practitioner who does cognitive behavioral therapy, for example, and see if you can, as a family, maybe educate that person in how they might work with your family member with an ASD. And I'm not sure if I mentioned this or not, but if I didn't, psychiatrists, some psychiatrists are wonderfully knowledgeable about kind of sort of all the different disorders at once. So if you can identify that kind of professional resource, that's really wonderful.
Okay, great, thanks. So I guess there's a somewhat related question about how to get cooperation from teenagers who may be resistant to seeking out treatment. Does this sort of go back to some of your comments about trying to find things that are rewarding first, or do you have any specific recommendations for sort of compliance, I guess is what this relates to?
Yeah, this is another hard but really important question. There is a new, well, it's probably not that new anymore, but new to me mode of, I guess not really psychotherapy, but anyway, sort of a psychological concept called motivational interviewing that tries to seek behavioral change in people or buy-in for other types of professional help by kind of a Socratic method of questioning that individual to see if what they don't want to change is actually getting them what they want in life. And I don't know that much about it, but to me it seems like that is those sort of principles might be an important place for research in the future about how we might motivate with people with mental health issues to sort of get over the hump of breaking through that anhedonia or lack of motivation to actually seeking help. I think it can be, again, I think it can be helpful to bring your children to their pediatrician or urge your adult to get to a general practitioner just as a first course of a screening, and maybe with medication or other help you might move to the point where you have more motivation to try other forms of help. And again, I keep coming back to this, but activating and invigorating sort of their schedules with things that they are good at, that they have mastery over. Sometimes if you have a case of really severe depression, even that is going to be really difficult to get that buy-in, but not for everyone. And so if you can sort of build in things that they have success in and are feeling good about, I think that might be a way to see just enough change that you can then hopefully get their help in working toward more change with other means.
Great, thanks. I think we have time for just one more question. And you talked a lot about stigma and some of the sort of general issues regarding actually both depression and ASD. And so from a societal position, what do you think we could possibly do to sort of empower and support individuals with depression and ASD in the future?
Yeah, that's a great question. Well, one thing, so I sort of left this open-ended charge, like we need to change and improve social acceptance of people with ASD, but we didn't really have the time to talk about how to do that. I think one thing that's already happening is self-advocacy for adolescents and adults with ASD. I think banding together is really important, and having a voice and having identity in sort of changing your own sense of who you are and how you do belong, in order to then have that slowly kind of impact the way the rest of the world, or influence the way the rest of the world sees your group of people. And so I do really like these movements. Online is a great way to get in touch with people. There are even conventions and conferences of people with ASD, and a lot of self-advocacy programs. So those are that might be another way to kind of shop around, but that's probably one of the first recourses that I would suggest.
Perfect. Well, thanks again so much, Dr. Gotham, for your time today. We really appreciate it. And thanks to everybody in the audience for joining today. And we'll be in touch about our next scheduled webinar in the new year in 2017.